is our first series and we can say the second part of that on a very important and prime topic of urology, that is non-muscle invasive bladder cancer. It will be a very practical oriented case based discussion, especially focusing on the diagnostic approach, and will be dealt in details by Joy sir. And uh, this after this discussion, we can open interactive sessions and questions. We can welcome questions from the house. Joy sir, are you okay with this format, or
Yeah, I'm okay
I
with
think,
this format, and so it's a very small subject. Also, it's very fast
sir,
as you take it.
sir, if I can ask our very own respectable president, sir, to just lay off the foundation and begin the program with this, our very own Dr. PK Mr. sir.
Thank you,
So if
sir.
you can have a few words on this
Welcome,
today's
welcome, Joy, to this
topic.
forum.
Thank you, sir.
This has
Thank you.
been brainchild of this council to
Yeah,
hold this kind of meeting every monthly, at least once, and maybe more.
yeah,
So I believe it will be very productive discussions, not only for the students but also for the practitioners.
yes.
I think this is the second, as Saptarshi told, this is the second talk that you are giving on a very relevant topic. So I believe I believe there is no point of introducing you. Saptarshi can give a formal introduction also, and then we'll go ahead with the topic. Okay?
Thank you, sir.
Right. Saptarshi, if you can
Yes.
introduce himself, I mean, introduce Joy to the audience. He is known to everybody, but still he
Sir,
can give a.
sir, as we all know, Joy sir perhaps require no formal
No.
introduction. We are very
Okay.
much aware of his teaching capabilities. So,
Yeah.
but what we are truly waiting for to have those pearls of wisdom and those diamond words from him. So, without any
Sure. So let's get
more time,
ahead.
so we can go get ahead with the discussion, sir. Thank you, sir.
Sure.
Thank you for the president, secretary, and all the office bearers for giving me this opportunity. Let's don't waste time and directly go to NMIBC, non-muscle invasive bladder cancer. As we already know, that has been. My voice is audible, I think.
Yes, sir.
Yeah,
Yes, sir.
yeah.
Very much.
The nomenclature has just changed from superficial to NMIBC now. It's no more superficial bladder cancer. Now, from all the guidelines, we already know what are the basic things, how to stage, what are the investigations to be done, and how to approach this case. But unfortunately, many of us and all over the third world countries mainly, the TUR BT is taken as a generic operation. It's a very small operation done somewhere, and patients are not told regarding the risk of recurrence and the risk of progression, and not told that this NMIBC is a lifelong problem and that will stay, and it takes cost as well as all the problems associated with. So ultimately NMIBC is a costly disease, so that we should understand. Second, start with this discussion that first suspicion, that goes to diagnosis, then risk stratification, and then this NMIBC also need MDT, that means multidisciplinary team approach, and then treatment. So for MDT we have to place some sort of evidences, the what evidences we have, and these evidences we get from all the imaging investigations from TUR BT specimen as well as TNM and grading. All these things we accumulate and place before the MDT for the ultimate treatment decision for NMIBC. So our approach today is only the diagnostic approach, not the treatment. Now, suspicion of a bladder cancer. This slide, I am just there is a timeline that flexible cystoscopy should be done within 14 days.
Sir, can we have the slides, sir? Or Mr. Nirmalo, can you just assist, sir, in sharing the screen?
Yeah. The permission has been given already.
Oh, sorry.
Permission has been given already.
Yeah. Not done.
Okay.
Just sorry. Screen share. Now, already it was just shared with you. You are not,
This
it's not
yes, sir.
visible, I think, no?
No, sir. Slides are not visible,
I
sir,
believe
yet.
you on share and again share. That will settle it.
Can Mr. Nirmallo share it? You have the PPT as sent by sir to you.
You can share it also. I have sent you.
Nirmaloda, are you on board?
Initially, it was visible. Yeah, share. I'm sharing just 1 minute.
Okay, sir.
Yeah.
Yes, sir. It's visible now.
It's visible now. Thank you.
Now it is visible.
Yes,
Thank
sir.
you. So NMIBC starts from suspicion, diagnosis, risk stratification, MDT, and treatment. There are 5 stages. Is it visible? My voice is also audible now, if I
Yes, sir.
assume.
Completely, sir.
Now, suspicion of a bladder cancer, these are all slides, everybody know about this, but there is a specific timeline. Flexible cystoscopy, whenever there is visible hematuria, flexible cystoscopy within 14 days, CT urography within 7 days of referral, or before cystoscopy or after cystoscopy where possible. MDT discussion within 4 days after diagnostic procedures, that means TURBT and all this imaging, and definitive TURBT is scheduled within 14 to 21 days if cancer is suspected. Now, previously there was a timeline that if this happens, then only I will do CT urography. Now, these things are gradually reducing and these are gray zones. Now, everybody, if on flexible cystoscopy show a see a bladder tumor, now people used to go towards either renal bladder ultrasound or directly CT urography without wasting time. Diagnostic tools, we already know these are the diagnostic tools. First, ultrasound, CT urography plus minus before or after cystoscopy, whatever is necessary. Urine cytology is number 1, Pirish system. Then MRI if necessary, then preoperative. So, visual inspection of the tumor by flexible cystoscopy is very, very important. Now, whether it is papillary, whether it is mixed papillary and sessile, and whether it is solid or sessile. So these are the 3 groups, and we can assume by seeing the appearance inside the bladder, this may be a muscle invasive or this may be a simple papillary lesion. According to this, we can change our treatment protocol according to TURBT based approach or MRI based approach, that I am coming to the next. Risk stratification, very easy nowadays. Just mobile is necessary. www.nmibc.net এটা দিয়ে দেবে, URTC risk group calculation, and last this 3 and 4, these 2 are for the patients who already received BCG. Cytology, just go through it for the students I am telling. The voided urine sample minimum 25 ml, not morning. It's a, I already saw in the WhatsApp discussion that it's a mid morning urine sample that after letting the first urine to go, otherwise it will show cytolysis. How to preserve it, and what is the sensitivity and specificity. In high grade lesion there is higher sensitivity specificity, lower grade lesions it is less sensitive and specific. Parish system 2022 should be implemented. All these 3 first 2 do not need any retest. However, if the 4th, if the Parish system came out to be suspicious, redo cytology, repeat korte hobe, and high grade malignant always. Now the AI algorithms now combined with the digital imaging. Now this is coming up as a very, very important VCOCYT test, 92% sensitive for high grade tumors. Just remember this is the new coming agent. Now, flexible or rigid cystoscopy, there are lots of arguments over that, but the rigid cystoscopy, as we know, it takes lots of pain, patient may not be, and all types of cystoscopes are necessary, 30, 70, 120 degree to look at the anterior bladder neck. for better visualization. That is painful, but it is also better for clot evacuation and see the tumor as a whole. But if there is no tumor, no clot, then flexible cystoscopy with back squeeze system is much less painful, and it gives a better visualization, and you can see all over the bladder where, and draw a bladder diagram to see where it is. But if there is clot evacuation, then definitely we have to use a rigid cystoscopy, but that needs in Western, we do it under local anesthesia, but in all other exam purposes and for Western and FRCS, rigid cystoscopy should always be done under general anesthesia, flexible cystoscopy under local anesthesia and the office procedure. Need for baseline CT urography, as I have already told, that gray areas are gradually reducing. We can do CT urography in first visit also if we look at a office cystoscopy that there is a bladder tumor. We can go through direct CT urography if available, if not renal bladder ultrasound. But these are the previous indications where we need the CT urography specifically. Now, for every of us who are practicing NMIBC, there are two things which are very, very concerning to us. Number one, in which group the patient is, risk stratification, low risk, intermediate risk, high risk and very high risk. These are the 4 risk groups. Risk means risk of progression. Remember that, not recurrence. Now, first we have to see risk of progression by the EAU risk stratification tool. Low risk, intermediate, high and very high risk. That is given in all books. Everybody knows that. And the actual risk of progression is approximately this one on average. It is given here. Now, after we know that this patient is having a intermediate risk, high risk or low grade risk, then we have to tell the patient, we have to counsel the patient. Otherwise, the patients are coming sometimes here and there, and once they have bladder tumor resected, they think that everybody has been done and no further treatment has been done. So now the second, the counseling part is become very, very important for us. So for this counseling part is very important nowadays, and what to tell to the patient, how the recurrence rate will be, and what will be the progression rate. Progression means conversion of NMIBC to MIBC, and the recurrence means how much in time it will come in 3-month cystoscopy or 6-month cystoscopy. Now these two models are very, very important. NMIBC net, sorry, that is scoring model. It shows only the progression. Remember, NMIBC net only shows the progression predictability. 2006 URTC scoring model, this shows both R and P, recurrence and progression. These upper two, these are the two important things. So www NMIBC net number 1, and these two calculators should be handy. It should be in the app should be in our mobile. And Omni calculator is very important because this calculator alone can calculate what is the risk and risk of the progression. However, if we use the NMIBC, it will show us the risk of progression only, remember. So these two are very important. So most of the NMIBC treatment protocol now includes Omni calculator, the second one. Thus third and fourth are patient, these only show the recurrence, and these are for what already treated for BCG. So step 1, assess the risk of progression. This is for us to classify low, intermediate, high risk and very high risk. This first step is for us doctors who are treating it. Second, prognostic models is for the patients to tell what is the risk of your progression, what is the risk of your recurrence, and that will tell us how will be the follow-up schedule. So this is very, very important. Now I will share all these slides afterwards. Now these are all given in the book. Now this is the NMIBC net. If you open the mobile, this will be the NMIBC. This will look like this: age, tumor status, number of tumors, but this only gives progression, as I have already told you. No recurrence is given. Now URTC. URTC is this is the Omni calculator. This is the Omni calculator. It will look like this, blue color app. So this will show you both the risk of recurrence as well as the risk of progression. So this is better. So URTC, GUCC probability of recurrence and disease progression is better. At the same time, you can counsel the patients what is your chances of recurrence and progression. So Omni calculator, this we should download in our app. I already have this app in my mobile. Now case 1, let us discuss. As we have already seen, there is a single tumor. On ultrasound, on cystoscopy, urine cytology is negative, 2 by 2 centimeter and 0.3 centimeter. On cystoscopy, there are 2 tumors here. Grade 2 prostate, trabeculation is there, no abnormal looking areas. How will you proceed? Now, it is the question for students. Now, in these cases, definitely there are multiple tumors and mid trigon. So, CT urography is necessary. So, when the CT urography, we can proceed in 2 ways. Once we see it, don't do anything. First, do CT urography and then do TURBT. If by chance we have done TURBT, then we have to wait for 3 weeks minimum for the extravasation or anything to settle down before doing a CT urography. So this is the disadvantageous aspect of doing CT urography at a later time after doing TURBT. So we always jump for the TURBT first, but CT urography in these cases is better before doing TURBT. Now CT urography, already the investigation are given here. Now optimize patient and coagulation status. TURBT, how? Now TURBT, as I have already told, it's not a generic operation. It's a very oncological operation, and there are Anderson 10 points quality indicator. These are the Anderson, I am not going in detail. Anderson 10 points TURBT quality indicator checklist. Early is given. This is the landmark trial in Anderson C in 2016 Journal of Urology. This is followed all over the world, this quality indicator checklist. But one important thing is the muscle fiber should be in the specimen. That is a surrogate indicator for a good quality TURBT and bladder diagram. Now coming to the TURBT procedure itself, bimanual palpation under anesthesia, insertion of the resectoscope, inspection of the whole lining, resection of the tumor, recording in a bladder diagram, and precise description of the specimen. These are the things. Now one question always asked, I assume that there are some students here. How can you assume the tumor size? Some people just use the cystoscopy and ureteric catheter. So this is imprecise. So always the assessment of the tumor size is imprecise. We have to take it for granted that it is imprecise. 2.5 centimeter, maybe 3 centimeter. The most practical point is to take the loop size. One loop size is equivalent to 1 centimeter, and just assess what may be the tumor size. And how to do risk stratification in this case? Omni calculator. Just use Omni calculator. That is for the patient. Risk stratification and NMIBC net. NMIBC net will give us progression. Omni calculator will give us progression, rate of progression as well as rate of recurrence, predictability. Now, single installation MMC in justification. There is another trial here. In all cases where we do TURBT, that is Anderson 10 point indicator, quality indicator always includes single installation. So single installation, what is the evidence in favor of this is that this Sylvester. Always remember this. This is the paper over which this single installation is based. Now the second question is that if no MMC is available in OT, what can we use? Usually MMC, where TURBT is done, it should be available in the fridge of the OT. OT fridge thake, and do we use it? If it is not available, what alternative we can agents use? The students always tell that there are epidubicin, pyridubicin and all these things. But the most important thing, just tell doxorubicin. Doxorubicin is easy to get. And some people always tell that there is no bleeding after TURBT. And again, another question is that, sorry, I have when to give MMC. Everybody knows that within 2 hours, but if not possible within 2 hours, within 6 hours it should be given. But the dissection should not be deep, no perforation and nothing that. And if there is no bleeding after TURBT, is the irrigation useful? Some people, some of our boasty, as I have done TURBT, there is no bleeding, white is coming. I have not no doxorubicin, no MMC in the OT, so I have stopped the irrigation and the patient is okay. Ideally, this is not true. Actually, if there is no MMC, no doxorubicin, no agent available, only give post-operative irrigation with normal saline. That will reduce the risk of recurrence, relative risk to 20% around. So only irrigation is also helpful if you don't have any MMC or doxorubicin in the OT. And no bleeding after TURBT, is irrigation useful? Yes, 100% it is useful. Use it. That is not for bleeding, that is for stopping the floating tumor cells to adhere to the other areas of the bladder. Now case 2, 70-year-old, visible hematuria for 5 months, diabetic on metformin, hypertensive, performance status 1. Cytology here it is positive for malignant cells. That means 5. And multiple bladder masses on adrenal bladder ultrasound, cystoscopy images. 4 lesions like this are seen here, less than 3 cm each on the left lateral wall, the trigone. Suspected reddish areas. The second picture is showing that suspected reddish areas in the bladder. How to proceed? There are multiple tumors. All are less than 3 cm and almost 4 or 5 tumors, and there are reddish areas here. Now, how to proceed? This is the different case. When there is reddish areas, we suspect that there must be some sort of carcinoma in situ. Now, carcinoma in situ never low grade, it is always high grade. It's high grade tumor but intraepithelial tumor. Now, how to proceed? In this case, we have to see whether I have PDD available in our OT. If PDD is available, okay, yes, TURBT and biopsy from the abnormal areas under PDD guidance. Very easily we say that I will do TURBT and then I will go for the biopsy of the abnormal looking areas under NBI or photodynamic or whatever is necessary, ELA or HLA. PDD is available. If not available, we will do TURBT plus biopsy from the abnormal areas under white light guidance. Now, one thing is important. Sometimes we ask them, TURBT I will do first or I will take the biopsy of the abnormal areas first. And second, multiple tumors, which one is to be done first? The question lies here, if there are abnormal areas, if we use PDD, the biopsy from the abnormal areas should be taken first and preferably with cold cup biopsy. Don't use loop. Cold cup biopsy, because suspected areas are most likely carcinoma in situ. These are not muscle invasive or propria invasive, lamina propria invasive. So wherever is possible, cold cup biopsy from the abnormal areas. So why we should do first biopsy of the abnormal areas? Because once we start resecting the main tumor, there will be bleeding and the blood will obscure the abnormal areas even after applying the PDD. Number 1. And number 2, if there is blood in the effluent, then the effectivity of the NBI, narrowband imaging or photodynamic, whatever we use, the effectivity reduced. So we can't see all these areas again. So first take biopsy and then. Now second question is multiple tumors, which one to be done? If the answer is, if any satellite tumors are small and amenable to removal with cold cup forceps, use cold cup forceps to remove the satellite tumors. But if it is a larger tumor, do the most easy tumor first rather than going for the difficult tumor. Suppose there is a tumor in the lateral wall which can give us to a obturator jerk, that will be done at a later time. The easy tumor should be done first rather than the difficult tumors. So this is the dictum. And second, mapping biopsy. What is the difference between biopsy from abnormal looking urothelium and mapping biopsy? All biopsies are not mapping biopsy. In this case, as there are abnormal areas, the biopsies we are taking, these are not mapping biopsy. Mapping biopsies with or without PDD is taken from the 6 sites: trigon, bladder dome, right, left, anterior and posterior bladder wall. When the cytology is positive, but the bladder mucosa looks normal on cystoscopy. So, mapping biopsy, the term is used only for normal looking mucosa with positive cytology. Remember this. Now, if there is, in this case, the biopsy is carcinoma in situ plus high grade T1 tumor, no LVI, no variant histology, what will be our next step? Now, everybody knows we'll take a second biopsy, second TURBT. Now, what is the evidence for second TURBT? We already know that already 40 to 50% upgrading, and there is residual tumor in the of around 40%. So, these things will be removed once we do a second TURBT. Case 3. Now, 75-year-old man, there is a solid looking tumor here, sessile tumor at the bladder neck, around 3 by 3 centimeter, 3 by 2 centimeter. Ureteric orifice is normal, bladder mucosa apparently normal, cytology is negative. How will you proceed now? This is a solid looking tumor. We have done flexible cystoscopy. Now, the approach, present approach is that we do flexible cystoscopy. We have seen there is some excrescences here. Just take a small cold cup biopsy from here. If there is a bleeding with bug B, you blot it. That small biopsy is sufficient to give you the histology as well as molecular material, molecular study if necessary. Immediately go to the MRI protocol. So, in this case, we may avoid TURBT driven protocol. In this case, we have to adopt the MRI driven protocol. Now, I am coming to this second slide. Cystoscopy, solid looking mass. So, the visible mass on flexible cystoscopy, how it is visible, papillary, mixed or solid mass, that is have an implication. There is 89% concordance level, that means almost 9% concordance level of what we see on cystoscopy. If we think that on cystoscopy there is a solid tumor and it may be MIBC, it may be MIBC in 90% cases. So, do take biopsy from the accessible area, do NMI, if it is NMIBC, virus score less than 4, TURBT. Virus score 1, 2, 3, do TURBT. If virus score 4 and 5, don't go for the TURBT, directly counsel the patient for radical cystectomy or trimodality therapy, or if the patient wants further or I am confused, then only I will go for TURBT. So, this is the latest bladder path trial that is came in 2025 and it's already in action in all European countries now. So, when we see some solid tumor, don't go for it, just take a small biopsy, revert back to MRI and see the virus score and directly go for the definitive treatment. If it is less than 3 virus score, TURBT, 4 and 5, go for the MIBC protocol. Now, this is the bladder cancer pathway. This is the conventional TURBT driven pathway, we already know. And role of biomarkers, nothing new. These are all maximum till theoretical. NMP22, BTS stat, Eurovision, FISH, and 6 bladder, and can help restratify the hematuria patients in triage but cannot replace cystoscopy or imaging. So, this is the ultimate takeaway point, that biomarkers cannot replace cystoscopy or imaging. These are just fancy things we are using till now, but patients, these are useful in follow up, not for diagnosis. So, thank you.
Oh, nice.
Thank you, sir.
I think I have completed within half an hour, sir. Yeah.
Sir.
Thank you. Thank you, sir.
Thank you, sir. As we could see, the concepts of management of bladder cancer, especially NMIBC, have really evolved a lot, sir, over the last few years. And you have really pointed out and highlighted many new interesting concepts. sir. It was a wonderful elucidation and a wonderful presentation, sir. So thank you. Thanks a lot.
Thank you. Thank you.
I would open discussions. So if any of you do have any questions, we can discuss it freely now. I
So,
will also urge the students.
so let me start with a question. I nicely told that the irrigation only reduces. Am I audible? No.
Yes, sir. Yes. Sir.
Irrigation only reduces the chance of local recurrence by washing away the floating cancer cells.
Yes.
But there is in our when I was in my training days, there was a concept that if you irrigate with water, distilled water, there is a possibility of inducing a lysis of these floating cells also. So
Yes.
we used to prefer distilled water over normal saline for irrigation.
Yeah, you are right, sir.
Any comment on that?
You are right, sir. Distilled water is a hygroscopic that will swell the cell and ota fete jay. The cells will blast.
Lysis, yeah.
Yes, but in practically distilled water is not available in
Not
OTs
available,
now.
that's true.
Not available in OTs. And the basis is that the tumor cells adhere to the bladder surface by fibronectin. So irrigation will block this. Yeah.
Sir, only regarding the irrigation part, any particular time or the amount that needs to be carried out for this, like the particular amount, or for how long post-operatively the irrigation needs to be carried out, sir?
Now, irrigation usually continue for 4 to 5 hours. So if we don't have any single installation therapy, so 4 to 5 hours is sufficient irrigation. But if we have given single installation, then we have to stop irrigation and keep the 1 hour, the 40 milligram 1 hour. The dose we have to remember in BCG and in MMC. In BCG 80 milligram 2 hour. In MMC it is 40 milligram 1 hour. The position does not matter. The previous concept of changing the position, all these things don't have here any implication.
Right, sir. So just from students' perspective, from exam-oriented questions, and also from our practice-oriented things, we often find patients who come up with an ultrasound report. Those are incidentally detected. There is a bladder papilloma, a solitary bladder papilloma, 1.5 centimeter, 2 centimeter. So according to the new concept, should we go for a CTU, sir, in these cases, or we will directly counsel the patient for a cystoscopy and we will proceed for a TURPT?
See, any case the patient came with a ultrasound. I have already told that gradually the line between the where to previously we used to study very lot 20 years ago. Yeah, we do CT only in case of when the tumor is more than 4 centimeter, is near the uretary orifice, it's near the trigon, multiple tumors. So these are the traditional indications for CT. Nowadays the difference is gradually decreasing because all the European countries and America, they have just started their ultrasound as well as CT urography before doing TURBT.
Right, sir.
So in
Sir,
all the guidelines now it is written that do CT urography if possible.
Sir, in our medical colleges, when the externals or they do ask questions, then it's my advice, you being the senior, all of you will be highlighting this more. The students should answer, I think, definitely according to the guidelines and also their institution-based practice also, because all the institutes may not have taken up the European guidelines. What we used to say in our institute, our professors, sir, we practice according to that. We do an ultrasound and we can proceed according to that, but the guidelines are now changing. I think this should be a ideal answer to give in the exam.
First
Sir,
ultrasound.
your opinion on this?
In our setup, it is first ultrasound and then do flexible cystoscopy. Flexible cystoscopy is not new. It is now available all hospitals, in all hospitals, even in bedside and in office cystoscopy also. Nowadays in India, flexible cystoscopy is available. First have a look. How many tumors,
Right.
what is the condition, how is the size and how it looks like. If it is angry looking, solid tumor, big tumor, immediately go for the MRI before going. So this is the protocol nowadays, not to go for TURBT. If we once do in a sessile or solid tumor TURBT, then if we do MRI after that, it will take 3 to 4 weeks to reduce everything and we will lose all the evidences.
Right. So there is a question from the house from Dr. Shumit Shatra. What is the role of urinary cytology in a case of diagnosed bladder SOL?
It is not important for diagnosis, but urine cytology is important. Urine cytology, as we already
Sir,
know,
any
in low
role?
grade, urine cytology in low grade, there is no value because there is less specificity and less sensitivity. In high grade, 90 to 100% sensitivity and specificity. The usefulness of it came only when you see your cytology is positive. Once you go inside with your flexi and you see that there is no tumor, then the problem of mapping biopsy and biopsy from the prostatic urethra and upper tract imaging comes.
Right, right.
Yes.
Mr. Sir, your take on any further concepts on
Yes.
this as sir presented?
Yeah, I believe Joyce shared a literature to justify the mitomycin installation in after TURBT.
Yes, sir.
Can you just elaborate on that? Solo is no that you cited a presentation. And how this has arrived at that the installation will be useful. How this concept came in.
This concept came in 2015. The Sylvester work. Actually,
Yeah.
we are taught like that. In BCG and MMC, এক্সামে যতগুলো কোশ্চেন আসে সিলভেস্টারের উপর দোষ দিয়ে দেন কে বলেছে সিলভেস্টার বলেছে বাট অল আর রিটেন বাই সিলভেস্টার ইফ ইউ গো থ্রু দ্য অল দ্য এভিডেন্স সিলভেস্টার কামস ইনভ্যারিয়েবলি one of them. So the 33% reduction rate in favor of single installation. 5-year recurrence rate decreased to 44%. Absolute reduction 14% versus 58.8% favor of SI. So NN to prevent one recurrence in 5 year, please see the slide, was 7 eligible patients and 10 randomized patients. So this is the evidence base. So there is definitely, but it will not prevent progression. We have to remember this. But all the evidences in bladder tumor, if any student is asked what is the evidence, where from, just take the name of Sylvester, it will cover everything.
Yes.
For exam purpose, yeah.
Sir, another thing in the third case, as you mentioned, if
Yes. Am I audible? Sorry.
Yeah, you are audible.
Yeah, in third case, this is a new bladder path trial.
Radical cystectomy done on a bladder which had a complete resection with TURBT had a better overall survival and recurrence free rate in comparison to a bladder who had residual tumor after TURBT. So your take on this, sir, regarding this result?
After the Virat score, we have to see if it is 4 and 5, then definitely it's a muscle invasive tumor. Then removing the whole mass, then I have to give the option to the patient what you want, whether you need a trimodality treatment and bladder preservation protocol or you need a radical cystectomy. Now these things will be, I have to give an option. I cannot dictate the patient because nowadays trimodality therapy has excellent result. And
Yes, sir.
Radical cystectomy is gradually under disfavor. So radical cystectomy is one pathway. NAC means neoadjuvant chemotherapy plus radical cystectomy, or my second option is just go for the TMT, trimodality therapy. If the patient wants trimodality therapy, then only TURBT will be helpful, and that TURBT is called complete TURBT, or a second nomenclature is the radical TURBT.
Okay.
Am I okay?
Okay.
Yes.
Okay, sir.
So in this regard, I'll raise another question. We are now depending on the MRI finding to stage the disease.
Yes.
Instead of a TURBT muscle invasion demonstration in the biopsy. Instead of demonstrating in biopsy, we are using the MRI.
Yes,
is
sir.
not it?
Yes.
So, is there any studies which compares say, transluminal ultrasound versus MRI in predicting this muscle invasiveness?
No, sir. There is no
No.
study like that. Only MRI based study is there. There is a bladder path trial just came in 2025, and that is a game changer nowadays. So if on cystoscopy we see that there is a solid tumor, most likely to be our appreciation of
Yeah,
the that is important. If
that's
we see
also
that
90% right. No, you told no.
yes, yes.
There is a concordance
Yeah,
of
concordance of
90%.
90% almost. So if you think that it's a muscle invasive tumor, don't do everything. Just take a small biopsy, come out,
And
and yeah, virus score.
why I'm raising this issue, a long back I was in some workshop in Nadiad. They were using intraluminal ultrasound, and
Yes,
uh,
sir.
and they were just say that this is muscle invasive, so we'll not go for any TURBT, only biopsy, and then we'll do a radical cystectomy. So this concept is actually very more practical and more
More
useful.
practical. Yes. And the second is that before doing TURBT, always we do transrectal examination, and after TURBT we repeat the transrectal examination, DRE. So if before examination we do DRE, and if there is a palpable mass, maybe it may be T3 or T4 or T2, whatever. But if after resection, if DRE feels yes, there is a induration still there, then it's definitely T3. So that is another indication. So that's why that digital rectal examination before and after resection is kept in the UA guidelines.
Right, sir. So, sir, I would urge if there are any questions from the house. If not, sir, if you can give some concluding remarks and few take-home messages regarding this diagnostic approach in a case of a patient who have presented with an renal ultrasound or a renal bladder ultrasound presenting with a bladder SL, few salient points which we should look upon the thing and how to proceed. I know you have already presented, just few salient take-home messages, sir, from
Take home
this.
messages, yeah, thank you. Take home messages are first do cytology, ultrasound, and then if the cytology is high grade, then we have to keep this and then look inside the bladder whether by cystoscopy rigid or flexible, and see the condition of the bladder, how the tumor looks. If it looks multiple fronts like masses and papillary, maybe it may be NMIBC, and then do TURBT. But if we see that there is a very solid and muscle invasive looks like muscle invasive tumor, we should go for the MRI. And the rest of the things we have to put before, because in our country it's not MDT, in NMIBC is still being neglected, but we have to put all our records, TURBT, pathology, cytology, patient's age, performance status, CT urography, CT chest abdomen, CT chest and abdomen. Everything we have to put before the MDT before take a decision what to do, whether it is intermediate, low risk or high risk disease, and accordingly if it is NMIBC the protocol will be followed. If it is a low risk, then single installation, no further, and follow up will be according to that. If it is high risk, then it will be G3T1, then we have to follow this patient up very frequently and give the option of radical cystectomy and this. Intermediate risk, we can start BCG.
Thank you, sir.
Thank you.
And Mr. Sir, if you can just put in your concluding remarks on today's discussion,
Well,
this
there are
academic discussion.
there are certain interesting learning points in this discussion today. One thing is we can bypass demonstrating muscle invasion in the biopsies before going for radical cystectomy if we have a high virus score. That is a very important learning point today. And one should insist on instilling mitomycin as far as practicable after a TURBT. That's also another important point stressed upon. I think it was a nice elaboration of we learned certain things. Thank you, Joy. Thank
Thank
you
you,
very
sir.
much. Thank
Thank
you
you.
very much for participating. And I believe we'll look forward for further participations like this. And we'll increase, probably will, this is, to my mind, this is a very useful exercise. I don't know how the participation is, I was expecting should be more, but then we'll continue with this in future. I believe once the people get a hang of it, that it is a very useful exercise, I mean, this session will become more popular. So
Thank you,
thank
sir.
you, Joy, for sparing your time.
Thank you. Thank you, sir, for calling me. Yeah.
Thank you, sir. Thank you, Mr. Sir, for an enlightening presentation. It was a nice discussion. I think the people who were in the discussion must have benefited from these novel points. Thanks a lot, sir, again, for being a part of Bengal Urological Society's this online academic endeavor. Thank you, sir.
Thank you.
And good night, everyone.
Thank you, sir.
Good night. Good night.
Good night.
Good night.